Okay, we're live. Good
All right.
evening. It is Monday. I almost said it was Thursday. I'm trying to rush through the week. It is Monday, October 19th, 2020. And we are delighted to have with us Dr. Laila Gharzai from the University of Michigan, who's a radiation oncologist. And also, after her name, it says LLM. And I just learned that she has a master's in finance and law. We're talking to Dr. Gharzai tonight about communication during the pandemic with oncology patients and physicians. She and some of her colleagues at the University of Michigan recently published a report in the Journal of American of JAMA. I'm just going to say JAMA Oncology on the perspectives in oncology specific language during the coronavirus disease. And basically, what they wanted to come up with was a communication guide to help patients and physicians be clear. So, Dr. Gharzai, would you please just open up, explain a little bit about this study and some of the outcomes you discovered?
Absolutely. Thank you very much for inviting me and having us here today. I'm very excited to talk about this study and some of the work that we've done. So I very much appreciate your time. This was an interesting, qualitative piece that we did, basically that stemmed from the craziness that was the pandemic back in March. As I'm sure all of us remember, I don't think any of us were expecting what happened to happen, and it uprooted and changed our lives completely overnight in a way that I always joke with, my patients and my friends, that if you had told us in January that this is what the world would look like and this is what we were living, someone would have said, no, that's some like crazy dystopian fiction, no way. But it happened, and it happened really quickly. And on the healthcare side, what happened was, especially here in Michigan, where, Detroit was hit so hard pretty early on, everything that we did cancer related and cancer wise was completely thrown for a loop. We suddenly had to start making really challenging decisions about, cancer treatment and when was the right time to bring people in. And suddenly all of our old risk benefit calculations got completely thrown out the window by the concern that we were going to spread this to people in the hospital. And it was just a really scary time for everybody. And one of the things that started happening was, well, it became actually more risky to treat somebody with cancer in some certain cases than it was, to delay their treatment just because of their risk of getting this virus. And we suddenly found ourselves having really, really challenging, very difficult conversations with our patients. And it turns out that in medical school, while we do get taught a little bit about how to deliver bad news,
Oh,
most physicians are not taught how to have these difficult conversations. So that was sort of the goal of developing the guide.
delivering bad news is kind of what oncologists have to do day in and day out. I just wanted to go back pre-March. My first indication that we were having a problem, I was flying to New York City around February 8th, and there was a young man in the waiting room in the Delta Lounge who had on a ski mask and swim goggles and another mask over that. And I thought, oh, we're in trouble. Something's happening. So, so this happens, and you all have to pivot really fast. What was one of the first things that you did? You said it was riskier for the oncology patients to come into the hospital for treatment. What recommendations did you make to them to ease their anxiety around not getting treated? Because I think when somebody's told they had cancer, they're like, we're on the treatment train here. Most of us, we'll get a second, maybe a third opinion, but we don't want to sit around and wait for you to decide if we can come in.
So I think even before it came to sort of talking to patients, what really happened sort of on the administrative and at the sort of physician side was sitting down and really thinking about all these different types of cancers that we have and all the different types of treatments that we have, and trying to actually figure out in this giant spectrum that is cancer care, who's at most risk for getting the virus and passing away from it, and who is at the least risk. And then on top of that, of these different, many different types of cancers, how do you understand the spectrum from, a sort of delay in treatment very much affecting this type of cancer versus a small delay in treatment not affecting that type of cancer? So there was a huge national, international, honestly, effort that came about with many groups sitting down and trying to with what little data and what little evidence they had, making guidelines for people and saying, okay, these are the types of cancer that absolutely should not be delayed under any circumstance. Here are the types of cancer that we can delay for a little bit if you have a surge in your area. And then finally, these are the types of cancers that are, going to do well no matter what. And these are the patients that we can give them some sort of small bridge, whether it's a pill, like a chemo pill or a hormone pill or something like that, until things get safer. So I think a lot of behind the scenes work, behind the scenes for the patient side, from the academic, clinician, physician side, very much in front of everyone's faces, where every single day we were seeing guidelines come out of, everywhere from Italy, from the UK, Canada, here, all just trying to triage and understand when we could and could not delay treatment. Once all of that was put into place, every department, or most departments, then sort of had this list of these are the types of cancers that we will do everything. Even if someone has COVID, we will treat them because we're so worried about this type of cancer, all the way down to these are the types of patients that we think can wait. And that's when sort of the actual conversations then come into play. And that's when, we start seeing patients and start having to say, man, if this had been a couple months ago, this would 100% be just a decision between me and you about, when to start treatment and getting things moving. All of a sudden, though, with the pandemic, we now have this huge public health lens that we must think about, where the physician is not only making decisions for the individual patient, but is actually making decisions about how do we keep sort of our general public and our community safe as well. And that's exactly the type of incredibly challenging conversation that prompted the development of this communication guide, saying that we don't necessarily know how to tell people, sorry, you can't get your surgery right now, and how to also deal with some of the anxiety that providers were feeling as well, because providers also don't want to do that to their patients.
So let's talk about, you said, the various types of cancer. So for our purposes, we're talking about breast. Now, possibly somebody with DCIS, an early stage disease, slow growing, they could wait. But what about that metastatic patient?
It's a good question. So even before getting to metastatic, I would take a step back and say, you're absolutely right. So there's the DCIS, early stage disease, and there's all the way to the inflammatory breast cancer that are very aggressive and that we would want to treat right away. So you're absolutely right. Within localized breast cancer, not metastatic, there is very much a spectrum. And even within breast cancer, trying to navigate and understand, who are the lower risk patients and who are the higher risk patients. Metastatic disease is interesting because it becomes its own, it is very much different from the localized setting, because in general, metastatic breast cancer patients are, or any type of cancer patients, are incurable. And everything that we're doing is trying to minimize the harms that we are potentially putting them through with whether chemotherapy, immunotherapy, whatever they're on. And importantly, the chemotherapy aspect of it, actually, if someone is getting some sort of chemotherapeutic agent, actually suppresses their immune system and then puts them at higher risk for, complications from COVID or catching COVID. So the metastatic setting is a sort of very challenging situation, because you're not only navigating the cancer itself, which in most breast cancers is actually sort of a longer natural history, but also navigating the side effects of the treatment that you're going to deliver. And importantly, when people are getting systemic therapy or, immunotherapy, chemotherapy, most of them are having to come into the hospital every single time to get it, right? We don't have sort of chemo chop shops where you can just like stop by the side of the road and they'll drip a little in you and you can be on your way. No, they have to actually come in, get checked in by their nurses and get vitals. And then they have to, actually get the chemo and see the other patients around them and stuff. So the metastatic setting is a particularly challenging situation. But within the localized setting, you're absolutely right. There's the DCIS, very early stage, hormone receptor positive patients, all the way to the inflammatory patient. And having to figure out how to navigate that very broad spectrum is very challenging.
So that goes really towards communication. So
yes.
Share with all of us how you actually, the study itself and the outcomes. And also we talked about the communication guide and then the ask, tell, ask method.
Absolutely. So I'm a resident, and I am sort of, as part of my residency, I'm a chief resident now, but last year was doing a fellowship in decision sciences here at the University of Michigan. And part of that fellowship was learning about qualitative research and understanding how we can just use different research techniques to help us in challenging situations. When this whole thing happened, we started hearing from some of our colleagues and other providers about the challenging situations and about sort of the very difficult phone calls they were having to make. And what we realized is, everyone's specialty is a little bit different in terms of what those types of challenging situations were. So we conducted a semi-structured small interview study with, I think of, you'll have to forgive me, it's been a little while since I did this project. I want to say about 8 physicians in different specialties. So Radonc, perfect.
4 women, 4 men.
Perfect. In Radonc, my specialty, medical oncology, surgical oncology, and 1 person in internal medicine as well. Just asking, hey, what are the types of really difficult situations that you're finding yourself in? And based on that, we came up with scenarios. So things like delaying biopsies to figure out if somebody had cancer or not, delaying the initiation of treatment, having to take a treatment break in the middle. And based on all those situations, we then sent out a survey to cancer patients, literally saying, this is the situation. What would you say if your doctor said this to you? And getting patient feedback and their reactions to each of those scenarios that we identified. Once we had those scenarios and once we had those example patient responses, then we sat down with a team from here at the University of Michigan from the Center for Healthcare Communications Research, and then all worked together as a group to devise example responses to each of those scenarios and patient questions or responses. What we noticed from the patient responses was that, as you might expect, a lot of them were emotional responses, right? I'm fearful, I'm scared, I'm worried, I'm anxious. Why are you doing this? And so part of the communication guide was general principles about how to handle those challenging emotions and situations. And that was sort of the first part of it. So some of what you were getting at, the ask, tell, ask approach, ways to sort of integrate general communication principles when patients are endorsing these very strong emotions. And then second, going through each of those different scenarios where we give an example of what a patient might say back to you if you're on the phone with them and you're telling them, hey, I'm sorry, I can't get this biopsy scheduled because the risk of, aerosolization from COVID is too high. We have to delay it. An example of how a patient might respond, and then an example of how a physician might respond to a patient. It was meant to be a very quick and dirty hands-on guide. Hey, I'm busy. I have way too much going on in my life right now. I have 100 people to call. Here's something I can just have up right in front of me and be able to look at this when I'm getting some of these responses.
So I know you, in your research, you said you use these 4 C's: context, consideration, caring, and commitment. Can you describe each one of those and how that would play out practically?
Absolutely. So those are just some, again, of the general communication principles aimed at sort of helping some of these challenging situations. The idea behind all of them is, we're all perfect communicators when we have plenty of time to sit down, to think, to devise each of our responses. But when you're in a tough situation, you can't always remember all of those things, right? You can't remember off the cuff of your head to remind somebody of the context surrounding all of their, cancer and their situation. Sometimes having a mnemonic like that, 4 C's, for example, helps you in those challenging situations because it's just sort of a linchpin or a reminder, a measuring stick, okay? When you're in there, remember, got to remind the patient about all the background information and about sort of why they're there today. You have to remind them that you care about them and that you're worried just like they are and that you understand where they're coming from. And you have to remind them that you're committed to them and that you're going to, actually sit there and be there with them. One of the biggest concerns that we heard about was people feeling like they were being abandoned, saying, oh my gosh, does this mean that, I'm not going to see my doctor anymore? Does this mean I'm not going to, be able to have contact with my team? So while all of us, again, would be in a perfect world with no emotions and no stressors, all of us would remember to do all of those different components. in a high stress environment, it can be really challenging to remember all of those things. So it's just meant to be a little reminder, a little mnemonic that you can say before you go into the room or before you pick up the telephone call, and just remind yourself of all those sort of cornerstones of a normal conversation that you just might be forgetting during the heat of the moment.
So that's on the physician side. Let's talk
Exactly.
about the patient side.
Absolutely.
I would think a patient could become very angry.
Yeah.
Possibly threatening, hysterical. What advice do you have for the patient because we're seeing, as I said earlier, Dr. Scott Gottlieb, former head of the NIH, is telling us last Sunday on CBS This Morning that he thinks we're going to have a huge resurgence, that we're 3 weeks behind Europe. So we may be finding ourselves back in mid-March in just another month or so. So this scenario could be happening again. How can I as a patient, manage my own anxiety and communicate with a physician or my care team without becoming angry or blaming or shaming?
I think the biggest thing to remember is that all of those feelings are incredibly normal. I mean, we all, cancer is the worst day of our life, magnified 1,000 times and having to go see 100 different doctors. We're not all expected to be on our perfect best behavior. And as physicians, we know that. We know, especially when we're seeing people in the hospital, we know that we're seeing people on probably what is the worst day of their life. So first, just remind yourself that it's okay to feel that way, and it's okay to be upset or angry. The really challenging situation with the pandemic is related to this whole public health focus and having to understand and remember that, unfortunately, unlike what we're used to, it's not about a communication or a situation where it's just myself and my provider.
Mm-hmm.
Unfortunately, when we are in this sort of situation, it is actually what I even consider as like the antithesis of the American way. Here in the US, we pride ourselves on individualism and autonomy. It is something that is so central to our culture in absolutely everything that we do, which is different than other places. Like, say, there are some Eastern Asian cultures where it's all about the collectivism and the family. So part of the reason why this is so challenging is just some of our deeply ingrained American ethos of this is individualism. I'm going to pull myself up by the bootstraps, and this is how we're going to do things. When we start having to make decisions where it's not a decision that we're actually making for ourselves, but a decision that is related to the collective good of all, it is just such a jarring notion, I think, and so different from everything else we do as Americans that in and of itself is stress-inducing. It is a whole different way of thinking. I think just acknowledging that it's okay to be upset and acknowledging that we are so far out of the waters in how we normally make decisions, that understanding that background is going to be just central to us to be able to navigate this situation. I think the reality of it comes down to, of course, you're going to be upset. Of course, you're going to be angry. It's just, we're all in this incredibly tough, incredibly challenging situation. And unfortunately, the best that we can do is just wait for our public health official to tell us when it's safe to do things and when we can, move on to normal lives.
I think that's hard to hear for a lot of people, and particularly somebody who's in treatment for what is potentially a terminal disease state. So let's talk about ask, tell, ask. Can you give an example? Shall I be the patient and you be the physician? Or maybe I should be the physician. I'll be the patient and you be the physician.
Okay.
Dr. Gharzai, I'm supposed to be in for my radiation the next 6 weeks, Monday through Friday at 2:00 in the afternoon. You are telling me now that I can't be seen. What am I supposed to do? How long is it safe for me to not have my radiation following my chemotherapy?
Wait, just to back up, am I the physician or are you I'm the physician? Okay. Sorry.
In real life, you're the physician. I would like to be Dr. McDonald, but I don't have the time at my age to get all those degrees. So you be the physician, I'm the patient. Yes.
Okay, sorry about that. That was a beautiful question. That's why I asked.
Do you want me to
for
repeat
you
it?
asking? No, that's perfect.
Okay.
So I think, the interesting thing is a lot of that decision making about delaying happens even before a patient treatment is actually scheduled. So it would be very rare for a patient, one, in this day and age, to even have 6 weeks of treatment, and two, to have things scheduled. But I hear what you're saying, and let's talk about sort of treatment delay. So one of the first things that you can do is just ask about the background. Tell me, what do you understand about what's going on in our community right now?
Had the mute on. So that is really, you're trying to find out from them where they're coming from
Exactly.
so that you can help to educate them if they're misinformed.
Exactly. And that's the biggest thing, is that a lot of people come in with these preconceived notions or these assumptions that when we're lay people, we just don't know are wrong, right? These are just what we hear on the news. And especially in the day of sort of misinformation everywhere, they could come in and say, I thought everything was totally fine. I thought it was all just a big hoax or something like that, right? So it's all about establishing that common ground and sort of the foundation of truth, so to speak, before telling them anything.
So Dr. Garza, you're telling me that I don't really have to have 6 weeks of daily radiation. What are some of the alternatives? And I don't mean alternative non-Western care.
Mm-hmm.
I mean, what kind of treatment alternatives are being offered to patients either who should be having chemotherapy or radiation?
Great question. So I'm assuming that we moved on from ask to last. So within the pandemic and things that we have done, we have actually dramatically changed some of the way that we do things, specifically to make it safer for people to not have to come in every single day. So as an example, there are some patients that have hormone receptor positive breast cancers that, in order to delay or not have them come in to get surgery right in the middle of the pandemic, they were given a hormonal pill or anti-hormone pill to take for a couple months until sort of the wave passed and it was safe to come in and get surgery. Similarly, some patients who did have surgery were then given this hormonal pill to sort of give them a little bit more time prior to having to come in every day for radiation. There are some options with changing up the chemo to change it to something where you don't have to come in as often. There have been changes or different ways that we've delivered radiation, where we've kind of adopted shorter courses, saying, hey, maybe we can try to do this quicker, understanding that we don't have all the data, but saying that the risks of COVID here outweigh the benefit of sort of the longer course of treatment. I think that the medical profession really, really sort of went out of their way to try to think outside the box and find ways to keep people safe.
I know this study addressed these 8 oncology specific COVID-19 related scenarios, and I just want to read these for people who may want to understand what all those are. So one would be the worst outcomes from COVID-19. Again, something to discuss with your physician. Delay in cancer screening. Why not? Delay in diagnostic workup. Delay in initiation of treatment, which we've talked about. Offer of non-standard treatment, which you've just explained, some of the hormonal blockers and things that can be done pre-surgery or post-surgery. The inability to admit it to the hospital for management. I'm not sure I understand that. The inability.
Sure.
Tell me about management.
Sure. So in general, when people have complications or problems from either cancer or their treatment, sometimes in rare cases, we have to admit people to the hospital. So one example might be if you are on chemo and your blood count drops, your white blood cell count drops, and you develop a fever. That could be a potentially life-threatening illness where we want to bring somebody in and manage them with IV antibiotics, something like that. In other cases, someone might have severe pain that we can't seem to get under control on the outside or as an outpatient, and we want to admit them in order to help with their pain or find a better pain regimen for them. In those situations, sometimes we have to think and say, okay, if your risk of getting COVID is higher in sort of a healthcare system where you're interacting with people, do we have to figure out a way to manage you on the outside or as an outpatient? So do we have to figure out a way to manage your pain, either with more frequent phone calls or try to get a visiting nurse? Do we have to figure out a way to give you antibiotics, on as an outpatient instead of as an inpatient? So there are some people who would have normally been admitted to the hospital in order to handle certain situations that we might be more likely to try to do as an outpatient out of fear of them getting this.
I'm looking at the potential physician responses for these 8 oncology specific coronavirus disease related scenarios. Where can a patient find out about these?
Sure.
Because I kind of, for me, if I had this question, I know I could go there and see some of these potential responses. It might dial back some of my anxiety before I actually had the conversation with the physician. And it might help
Absolutely.
me ask more direct questions or a follow-up question, which I guess would kind of be ask, tell, ask.
Absolutely. So the publication itself has been published, and the guide is freely available as part of that for people that have the subscription. We do have an internal University of Michigan version, but that has some contact information about ways to get resources to patients, so that is not available outside the system. There is a free guide that was developed by Vital Talk, which is the organization that sort of inspired all of this. They're based out of Seattle. They're an amazing organization that focuses on communication in general, helping providers communicate better, that has a similar guide as well for the COVID-19 pandemic that is focused more on the inpatient setting. So there are definitely resources available online.
So I could just Google Vital Talk and find some of these resources to be able to share. So we'll make sure that we get that on our website. So Dr. Gharzai, we have just a few more minutes. Anything else that you would like to share to help patients through this fall and winter season when we're being told probably can't get together with family if you're in treatment for cancer? What recommendations do you make for protections in addition to facial coverings and social distancing?
I think the biggest thing that we have all learned, or at least I have learned, is how important some of those social connections are. I don't think I fully appreciated coming to work every single day and saying hello to people in the hallway until I was no longer allowed to come into work every single day and couldn't see those people in the hallway. I think we all collectively need to recognize that mental health is probably going to be the most important thing for all of us to focus on in this short time, while we're dealing with this pandemic. Whether it's checking in on your loved ones, making a list of friends that you're going to reach out to every single day, making sure that you have either Zoom dates or FaceTime dates or whatever it is, application that you use to check in on people. Because sometimes when the people are not reaching out, that doesn't mean that they're not feeling lonely and they don't need people. I think one of the challenges we are going to face as a nation is doing everything that we can in order to tamp down this second wave and this resurgence. We are all seeing very scary and worrying things where, some public officials are walking around without masks and saying that this is not a concerning thing. And I am personally very worried that we are going to get back to sort of the March levels and that things are going to go in that situation again, where unfortunately we're going to have to use this communication guide. It is a situation and a time in which we are being asked to look out for one another and help one another in order to be able to try and prevent this from spreading or hurting or killing more people than it already has. I think those are the two big things that I think we're going to have to watch out for in the coming months: doing everything we can to prevent the spread and checking in on our loved ones and our friends to make sure we're all doing well during this difficult time.
Dr. Gharzai, thank you so much for this time together. We look forward to putting all this information on our website. This video will be available on the Pink Fund's Facebook page and on YouTube. I also want to thank Exact Sciences, the makers of the Oncotype DX test, for sponsoring and underwriting this series for us. We're going to check back in with you in a few months and see how things look and maybe how they've changed, what providers have learned, and what kind of patient care is being offered. So I'm going to say good night. Stay safe, right?
Yes.
I will add one thing that I have suffered a little bit with my mental health recently, and I just from the lack of human contact. I was used to traveling 12 to 14 times a year and going to conferences, and I can't see my family like I used to. So we're all feeling that, and it's tough. But as you said, we have to sometimes make sacrifices for the public health, the good of our communities. So for that, I'm going to say good night. Thank you very much. This was very, very informative.
Thank you, Molly. Have a good night.
Mhm.